It's 3 o'clock, so I think we're going to go ahead and get started because we have 11 wonderful speakers with very exciting topics. I have a feeling this is going to be one of the best Pediatric Ophthalmology and Strabismus Symposium at the APAO. So again, thank you very much for coming today. I would like to introduce our panelists, and then we have 11 speakers, and each speakers will speak about 6 minutes, and then we'll have 2 minutes for questions and answer for each one. And so this is a rapid fire pediatric ophthalmology and strabismus update session, and thank you very much for coming. First, we have Dr. Amar Pujari from India, and the second panelist is Dr. Miho Sato from Japan, and I'm Donnie Saul from US. Thank you very much for coming. We'll have Dr. Sato present the first speaker.
Okay. The first speaker is Mason Burns. The title is Sporadic Orbital Burkitt Lymphoma in Pediatric Population, a case series and review of the literature. Dr. Burns, please start.
Good afternoon, everyone. My name is Mason. I'm a junior doctor from Sydney, Australia, and today I'm presenting a case series and literature review on sporadic orbital Burkitt's lymphoma in pediatric patients. I have no conflicts of interest or financial disclosures to declare. So a bit of background, Burkitt's lymphoma is a highly aggressive B-cell non-Hodgkin's lymphoma with a doubling time of approximately 24 hours. It was first described in 1958 by Dennis Burkitt in children in sub-Saharan Africa with rapidly enlarging maxillary and mandibular masses. Global consensus agrees on 3 distinct subtypes of Burkitt's lymphoma: endemic, sporadic, and immunodeficiency associated. The endemic subtype is the most common form of Burkitt's lymphoma. It has an incidence of approximately 3 to 6 cases per 100,000 per year in Africa, and its distribution is closely associated with EBV and Plasmodium falciparum malaria. The second is sporadic Burkitt's lymphoma. It's the most common form outside of mainland Africa and has an incidence of 3 per 1 million per year and is responsible for 30 to 40% of all pediatric non-Hodgkin's lymphoma. The third and much more rare type is immunodeficiency-related Burkitt's lymphoma. It's associated with HIV and less commonly post-immunosuppressive states after solid organ transplant. The pathogenesis of Burkitt's lymphoma is not well understood, but it's believed to be because of an overexpression of the MYC gene and has a characteristic 814 translocation. EBV infection is present in virtually all cases of endemic Burkitt's lymphoma, however, only in 30 to 40% of cases of the sporadic and immunodeficiency type. The exact pathogenic mechanisms of EBV causing Burkitt's lymphoma is yet to be elucidated, but is believed to be due to an overexpression of specific viral proteins which promote cell survival and proliferation, leading to genetic instability and potential immune evasion. We retrospectively reviewed the cases from 2010 to 2024 at 2 quaternary paediatric referral centres in Australia for cases of Burkitt's lymphoma with orbital involvement. We found 4 cases and we'll present one of them. This case is of a 5-year-old boy who presented to the emergency department with left facial and periorbital swelling and numbness over the V2 distribution for 2 weeks. His systemic evaluation noted no lymphadenopathy, no history of malignancy, otherwise well, no recent illnesses. Ophthalmic assessment showed normal visual acuity, pupils equal and reactive to light without a RAPD, pressure was equal bilaterally. He had a left inferior globe dystopia and a limitation in supraduction of the left eye. All other ophthalmic assessment was normal. He was referred for urgent MRI imaging, which demonstrated a left orbital post-contrast enhancement and signal changes, including diffusion restriction, particularly in the superior temporal region. He underwent biopsy of the left lacrimal gland and superior orbit, which showed a characteristic starry sty appearance formed by dense sheets of monomorphic lymphocytes and pale staining macrophages, which can be seen in low and high power H&E stains here. The immunohistochemistry was positive for CD10, CD20, c-MYC, and has a high Ki67 proliferative index of 97%, negatively stained for CD3, CD5, BCL6, and CD30, confirming a diagnosis of Burkitt's lymphoma. Cytogenetic testing demonstrated an atypical MYC IgH translocation of 814, which has been previously reported in Burkitt's lymphoma, and there was no abnormality in BCL6, IgH, or BCL2. A lumbar puncture was performed, which demonstrated CNS-positive lymphoma and was placed on chemotherapy following the FAB LMB 96 guidelines for adult non-Hodgkin's lymphoma, and received 6 cycles of intravenous and intrathecal chemotherapy. He achieved complete remission and remains disease-free at 7 years follow-up. On review of the literature, there were 28 pediatric cases reported. Demographics have a mean age of 12.5 years, with a male preponderance of 68%. The common ophthalmic findings were proptosis, ophthalmoplegia, and inferior dystopia. 80% of the cases in the literature presented with systemic involvement and 20% with CNS disease. There are interesting age-related differences in the genes that are mutated in Burkitt's lymphoma. Higher frequencies of ID3, DDX3X, Iridia, and SMARC-A4 genes are seen in pediatric populations, while genes such as BCL2 and YY1AP1 are exclusively seen in the adult population. The presence of TP53 mutations are predictive of relapse, with 25% of cases with TP3 positivity and 6% of TP3 negative cases having relapse. Our cases were all treated using the FAB LMB 96 guidelines. This treatment protocol has an 82% survival rate at 4 years in patients with high-risk CNS disease. The overall cure rate for Burkitt's lymphoma is great at 90%, but a recent multi-center study has examined prognostic markers for Burkitt's lymphoma and identified 3 important biomarkers: platelets of less than 254, albumin of less than 40 grams per litre, and lactate dehydrogenase of greater than or equal to 334 international units per litre. Patients with 1, 2, or 3 of these risk factors had survival rates of 88, 72, and 45% respectively. So in closing, sporadic orbital Burkitt's lymphoma is rare but aggressive. It presents as a rapidly enlarging mass and mimics other orbital tumours. Early diagnosis is critical to prevent CNS spread, which significantly worsens prognosis. I believe ophthalmologists play a key role in early recognition and referral.
Thank you.
Thank you.
Are there any questions from the audience? So thank you very much for presenting a very rare case. And I think the treatment method or diagnosis has extensively progressed in this 14 years. Is that right?
Yeah, exactly, yeah.
Okay. Thank you very much.
Thank you.
Actually, I just want to ask you a real quick question since we have a minute.
Yes.
The presentation, the clinical presentation, the progress looks very similar to rhabdomyosarcoma, as you see. What are some of the things that are different than rhabdomyosarcoma with the Burkitt's lymphoma? And also, in terms of the biopsy, like, is there any tips of what areas that we should go for? Or what are your thoughts there?
So most of the literature, I'll answer the second part first. Most of the literature does biopsies the facial mass because they nearly always present with proptosis with some surrounding swelling. So they're just biopsying that mass. And in regards to rhabdomyosarcoma, Burkitt's lymphoma doubles much more quickly. So they generally present with a 1-week history of very, very mild swelling that then progresses to significant swelling with visual changes, proptosis, and
Thank you.
Thank you.
Thank you, everyone. Now we'll move on to second presentation. That is Dr. Samira Irfan. She is going to present on is surgical intervention avoidable in congenital NLDO. Dr. Samira, please. Is Dr. Samira here? They are nodding no. No?
Okay. Then we'll go to the third. Sorry. Thank you. We'll go to the third speaker. The multimodal imaging assisted surgery in traumatic strabismus. The presenter is Dr. Amar Pujari.
Thank you, Dr. Dear chair colleagues and all the colleagues here who are attending this conference. So I'll be talking on multimodal imaging, that is combining 2 imaging or 3 imaging modalities, that is AIOS2025 plus along with CT scan or MRI when you have traumatic strabismus, right? So before introducing how we can use these 2 modalities as a combination, so I want to say something about how to identify the rectus muscles using AIOS2025, which is an evolving topic. These are my publications you can see. So once you take out, this is a lateral rectus muscle scan by adducting the eye. So you need to follow 4 features. One is ocular coat contour. You can see that there is a smooth ocular coat contour. There is no bumpy surface or there is no irregularity, which means that this is a naive eye. And depth of hyperreflective layer. It should be somewhere between 40 to 50% depth from the ocular surface. And intensity, it is hyperreflective. And it is continuous. It is not in bits and pieces. If you take the ocular scan and if these 4 features are fulfilling, then you can identify this as a normal rectus muscle, right? So by adducting, you can see this is a medial rectus muscle and this is an inferior rectus muscle. This is the lateral rectus muscle and this is superior rectus muscle. So this is how you are going to correlate 4 findings and that's how you can identify the muscle. So you can also identify the muscle belly and the tendon very roughly. You cannot say 100% this is a transition zone between the tendon and the belly, but somehow you can say this is quite clear that this is belly and this is a tendon. Of course, tendon is going to be thin. You can see tendon has more noise and the belly has more of blackish discoloration. So in the same way, by good amount of abduction, you can see 9 mm of MR. This is the maximum amount we can see. We are telling that one. And by good adduction, you can see up to 11 mm of lateral rectus and around 3 to 5 mm of for superior rectus and the inferior rectus. These are my initial 3 publications where I studied in loss details how AIOS2025 is useful for like resurgical planning. Second one was like to what all extent, what all different condition where we can use, where I imaged around 1,104 images, muscle images. Third one was in slip rectus muscles. So this is the fourth thing where I want to tell. So this is a 44-year-old male patient who had trauma to the right eye and who presented with hypertrophy in the right eye and he wanted to undergo surgery for diplopia cure. So we did CT scan. In this sagittal scan, you can see that this is left eye, right eye is hypertropic. And if you see the contour of the left inferior rectus muscle, the belly is there. There is a smooth transition as the tendon and it is attaching onto the sclera. Here you can see that the belly is quite bulged and the anterior tendon is stretched. And it is, we don't know exactly where it is attaching onto the sclera. So these are the coronal section which says that in the anterior portion, the tendon is thin in the right eye and it is quite bulky or the normal bulk in the left side. And if you go towards the orbital apex, you can see that the corresponding belly bulk is here in the right side and it is normal bulk in the left eye. So in these cases, we don't know where the muscle is. But if you do the OCT and you follow those 4 protocols and you can see that the hyperreflective layer is at roughly 50% depth and it is continuously visible. These black congenital edema is because of trauma that has healed, right? So this is how we can identify the muscle and you can explore the muscle. See, we have explored the muscle. This yellow part indicates that is the fibrotic part and this pink part indicates the normal muscle. So we shape the margins of the rectus muscle, then we are going to placate it or advance it. So this is the second case. Similarly, you can see that rectus muscle bulging is happening here, right? And anterior tendon thinning is happening here. So this is a right eye scan and this is a left eye scan. You can see there is a scarring, but you can see that the hyperreflective layer is somewhere here. So which you can measure, and before opening the conjunctiva, you can mark it on the sclera, then open the conjunctiva. So that you will go beyond 6 or 7 mm, then you are going to hook and then you are going to bring the muscle anteriorly. So this is the intraoperative course. You can see that the muscle is torn here, it is posteriorly. But because we got the information on AIOS2025, we went behind that one, we tried to hook the muscle and that's how we retrieved the muscle. So this is one more patient. You can see the left eye hypertrophy because of trauma. There's a lid notching here. And in the left Leo version, you can see hypertrophy is there and infraduction is impaired. The inferior rectus function is impaired. So if you do the OCT, you can see the muscle. And here you can see if the rectus muscle, if this is 100% width on the nasal side, you can see around 20% rectus muscle is torn. So you do the rectus muscle plication and SR recession because superior rectus was tight and he has, we have achieved the orthophoria. At the same time, we give the infraduction function, which cannot be given by transposition, right? So that is the impact we are going to create by combining the multimodal imaging. So what happens is in trauma, when there's an anterior transection rectus muscle, it can be 10%, 20%, or it can up to 80% partial tear of the rectus muscle, which can happen in the anterior portion, right? So once it happens, the muscle relaxes. It becomes like a relaxing myotomy. So that's how the muscle relaxes. And the gap is filled by the fibrous tissue, which we saw in the first case. This is the D picture corresponds to the first case, and the C picture corresponds to the second and the third case. So in these cases, what happens is the length has increased, the tension has gone down. So that's why you need to placate and advance the muscle. That's how you can improve the strength and infraduction. So this is the fourth article which we published. The limitations are whenever there's a dense scarring, you won't be able to see. That is one of the major limitations of AIOS20. You saw in the second case. We are able to see only the anterior portion, and dense scars you won't be able to see the much posterior aspects. And of course, it says only about the scleral course of the rectus muscle. It won't tell the belly, which we need to get from CT scan or MRI. So to conclude, we can combine the AIOS20 and CT scan MRI just to know the insertional details using AIOS20 and the belly details using the CT scan or MRI. That's how we can use these two modalities together just to improve the individual patient deviation. Thank you.
Great presentation. Any questions on this particular topic? Please, we only have, we don't have a lot of people in this room, so please don't be shy. We actually are going to have plenty of time. So if any...
No, it's a simple MRI. Because dynamic MRI, when you want to know the muscle function, how muscles are like contracting and relaxing with eye movements. In those cases, we want dynamic MRI. This is a plain MRI without any dynamicity. We are not stimulating. That is a different story. If you are like congenital cranial dysfunction disorder, you want to know the pulley pathway. In those cases, we want more of a dynamic MRI. It's a simple plain MRI here. Patient will be looking straight. You are getting the MRI. We can get. Yeah, definitely. There is a way for that one also. I didn't do any dynamic MRI here. I did only simple static MRI. So you can consider dynamic MRI also.
Any other questions?
Yeah, I'd like to give a comment. I think dynamic MRI is very useful for observing the muscle belly, but we need to know, sometimes we need to know the insertion site.
Exactly.
In that time, the anterior segment OCT is very useful.
Yes.
We do use it for reoperation cases without with unknown history. We don't know the history of surgery, which muscle was operated. If we check, we are using
exactly.
like that way.
Because it could be traumatic injury, it could be resurgery, anything it could be. But ultimately, you want to operate on the scleral portion of the muscle. That's the truth. So that's why if you do ASOT, you get some sort of information. Out of 10 cases, you might get information in 8 cases. 20 cases might be outliers because dense scarring, some other limitation could be there. But if you combine the orbital details, which cannot be visualized on CT scan, ASOT, you can get the CT scan information, what is happening in the orbit, traumatic cases, orbital floor fracture is there, incursion of the rectus muscle is there. You can combine those information with the way the rectus muscle lies on the sclera before opening the conjunctiva.
Mm-hmm. Yeah, I think he was showing the examples of the trauma just as an example, but the main focus of this OCT is to help us to determine the exact location of the insertion. So it's not just useful for like traumatic cases, but if you think about the slipped muscles or lost muscles, I think that'd be interesting. But my question to you is that, we talked about the belly of the muscle. How about like do you see any potential benefits of using OCT for enlarged muscle, like for example Graves' disease, and trying to quantify and correlate with surgical outcomes? What are your thoughts there?
We did in thyroid eye disease, Graves' disease.
Yeah.
So in that case, we wanted to quantify the muscle thickness, how it is going to vary.
Yeah.
Because we don't have any muscle-specific progressive indicator. So if you consider my corneal diameter is around 11 mm, the rectus muscle is somewhere around 9 to 11 mm. So roughly the corneal diameter corresponds to lateral rectus, superior rectus, medial rectus, and the inferior rectus. So when you are taking the scan, try to take the scan through the center of the pupil, because we'll be at one position only. So what limitation we found is next time we are taking the scan could be slightly higher or lower. So that can vary with thickness of the muscle.
Yeah.
So that's why it was not reproducible. But of course, you can see there is an enlarged muscle. But if I want to repeat and say after 3 months or 6 months or 1 year, patient is progressing and the muscle is progressively enlarging, I'm not dead sure that I'm taking at that particular point only. Because it's in microns. The scan line can vary above or below. 5-10 microns here and there, the muscle can be thicker or thinner. That's one of the limitations.
Thank you.
Thank you very much.
Thank you.
Let's move to the next speaker. Dr. Ashok Sharma, AP of conventional versus accelerated corneal collagen cross-linking for progressive keratoconus in children? Please, Dr. Ashok.
Good afternoon, everybody. I will be speaking on epi of conventional versus accelerated collagen cross-linking for progressive keratoconus. Keratoconus, as we know, is a common corneal problem in children, and the incidence is somewhere 1 in 3,000. But when we compare to the geographical epidemiology, the condition is much common in Asian countries, including India. Asian countries, because of the allergy, because of the eye rubbing, this progresses faster also. Compared to the adults, the disease in children is not only more common, it progresses faster. It occurs in Asians, it occurs at an early age also. And this is, once it progresses faster compared to the adults, and may need penetrating keratoplasty at an early age. In this study, I have no financial disclosure. As far as the treatment is concerned, the epi of collagen cross-linking introduced by Professor Theo Seller is the gold standard. And this protocol requires mainly 1 hour total duration, because we have to have the soak the cornea for half an hour, and then we have to expose it to the UV light for half an hour. And in children, it becomes very difficult to have cooperation for 1 hour. So epi of accelerated procedure has been introduced, which takes less time, and we get more cooperation from the children. But the efficacy and the comparative studies are not many. So present study, I have evaluated the two protocols in children. This is a retrospective study and comparative and interventional case series. We have two groups. In conventional, we had 82 eyes, and in accelerated, we have 68 eyes. This is the protocols being used. We have used topical anesthetic drops, and then we have debrided the central 7 to 9 millimeter of the epithelium. Then we have instilled the riboflavin, 20% dextrose solution every 5 minutes for 30 minutes in standard. Whereas in the accelerated, we have used it only for 20 minutes, and then we have used 9 milliwatt per centimeter square UV light exposure, 370 nanometer for 10 minutes only. And at the end of the surgery, we have washed out the riboflavin, and we have applied bandage contact lens in all the patients. All the patients, they were given post-operatively topical steroids, some lubricants, and topical antibiotics also. These are some of the parameters which we recorded retrospectively. This is some of the cases where we have done in standard CXL topography, and post-CXL topography is much better. And again, in accelerated condition, the accelerated collagen cross-linking, the topography is better. These are some of the parameters which we evaluated. We looked at the flat K values, and these values in standard CXL group decreased from 47 to 46.01 at 4.8 years, whereas in accelerated were 49 to 45, flatter one. The steep K values from 51.53 to 49.7 at 4.8 years, whereas 49 to 48.9 at 2.1 years. Mean K decreased from 48.97 to 47.60, and 47.85 to 47.19 in accelerated group. The preoperative visual acuity was 0.8 and 0.62 in both the groups, and there was improvement during the follow-up in best corrected visual acuity also. This is one of the our publication where we have presented some of the complications. These patients were referred to us for management, particularly from one center only, and this machine was also evaluated for any like extra UV light or standardization and all that, but nothing could be found. But these patients, they had these problems, and some of these patients we did even penetrating keratoplasty. Fortunately, in our series we could not get any serious complications. Few patients we had corneal haze, which was persistent more than the normal, and some of the patients developed sterile infiltrates because of the bandage contact lens. I didn't encounter any in any of the cases like infective keratitis. All the children who had allergic conjunctivitis active, we treated it. Then only we subjected them to the collagen cross-linking. These are some of the other published reports. In conclusion, I would like to say that epi of conventional and accelerated CXL are safe and efficient for progressive keratoconus in children. Accelerated and conventional CXL are comparable, and both are viable options for keratoconus. Thank you so much.
Are there any comments or questions? Are there anybody familiar with corneal cross-linking for children? I have no experience. How about?
So actually, I mean, I don't do it personally, but I do refer patients, especially with Down syndrome. In United States, Down syndromes, that's one of the conditions that's underdiagnosed. And I'm actually seeing, I don't want to say many, but I do see, I think we have a higher awareness of patients with Down syndromes with this, especially in pediatric population. So let me ask you this. So what?
Very true, sir. In Down syndrome, the incidence of keratoconus is much higher.
Yeah.
And the results of collagen cross-linking are also not that good. So if a patient with the Down syndrome plus keratoconus comes to me, I will go for the standard CXL rather than the accelerated CXL, because that is the gold standard.
Okay.
And when we are getting patients in our country, we are getting Down syndrome patients with keratoconus at a very advanced stage. And there are very few patients where we can do collagen cross-linking. We have to do either deep anterior-lamellar keratoplasty, or in some of the patients even penetrating keratoplasty, because neither the parents are aware, children cannot tell them. So this is a special group, and I have operated almost 15 to 20 children with Down syndrome, whom we have done deep anterior-lamellar keratoplasty and penetrating keratoplasty. And even the post-operative period is very difficult to manage. Reason being that you will be surprised that sometimes the child irritates the mother. And one of my patient who was operated by me, and mother got irritated and she slapped. And the child developed the wound adhesions. We have to take him under GA. We have to resuture, and so these are special children and need special care. And in our country, we are getting these keratoconus patients with Down syndrome at a very advanced stage. So we are very fortunate, and parents are fortunate if they bring it early.
I see. So how the time difference, the standard versus the accelerated, what's the time difference?
It's almost like if we do the standard, we need 1 hour.
Right.
And if we do accelerated, we need half an hour.
Half an hour. So do you ever do the, especially in pediatric populations where they may not be very cooperative,
right,
even for 30 minutes, do you use a ketamine, or what do you do for anesthesia?
If I'm not very sure that this child will cooperate under topical anesthesia, I operate these children under general anesthesia.
Oh, general anesthesia, okay.
And then I have to do, if they need surgery, then I have to do both eyes together. So I don't want to put him under GA again for the other eye.
So that were the two questions what I was asking. Which type of general anesthesia do you prefer? Intubation or only IV, and that would be suffice?
No, I go for the general anesthesia. I don't want to risk with
general
other.
anesthesia, but with the intubation.
Intubation.
So because then there would be a problem with the Bell's phenomena. We can't get the centration for that UV light. Sometimes the eyeball little rolls up.
We do rotate the eye with the forceps and try to make it center.
So continuously 10 minutes we have to keep hold that eye.
Definitely. When I am treating my patients, I have to sit there.
Yeah.
It's
so
not that I don't sit there and patient is being operated.
Okay.
Yeah.
And what would be the post-op regime? Because if you do the bilateral in the same sitting, So do you prefer the bandage contact lens or patching?
I always use bandage contact lens for my patients. I have stopped using patches long time back.
Immediate after post-op, not for a single day?
Only bandage contact lens.
Okay, so
Unless the child is very small, or if there is a very, like some of the patients come from very poor socioeconomic status, I am operating only on one eye. I don't want to take the risk of infective keratitis. Then I put the patch. Otherwise, I use bandage contact lens, because all the children, mostly they are above 6 years or so they do understand everything and they are able to cooperate.
so what was your experience with the bandage contact lens? Within how many days it recovers?
I usually remove contact lens after 72 hours, but it all depends upon, sometimes the child may not be able to come after like 72 hours, then 96 hours, or maybe a day more, but
Thank
not
you.
more than
Thank you
5
very
days.
much. Time
Yeah.
is up.
Thank you,
So-
thank you, madam.
Thank you so much. We have next speaker, Dr. Thi Hang Tran. So he's going to present on combined extraocular muscle fenestration with Jensen technique in the management of chronic six-nerve palsy.
Hello, everybody. My name is Hang Trần Thị Thu from Vietnam National Eye Hospital. Today, I'm very honored to be here and present about the topic combined extraocular muscle fenestration with Jensen technique in management of chronic signal palsy. We have no financial interest to disclose. The abductional palsy is the most common ocular motor paralysis in adults, and the second most common in children. The most common cause in Vietnam was trauma with 56% of patients. After at least 6 months of follow-up care, if the remaining astral deviation is still unacceptable and it is too large to be corrected by a prism, the corrective option should be discussed with the patient. The procedure that is chosen depends on the remaining function of the lateral rectus and the secondary medial rectus contracture. If the patient cannot abduct the eye beyond the midline, for abduction tests for medial rectus and active force acceleration tests for lateral rectus need to be done. And in a case with severe complete signal palsy, transposition should be considered in conjunction with the medial rectus resection. However, when we do both techniques for the patient, we have to face with the high risk of anterior segment ischemia because we can operate on multiple muscles in the same eye. To reduce the high risk of ASI, we do a special surgical procedure, the fenestration technique, to spare the ciliary vessel travel in medial rectus. In this technique, the muscle was exposed through chronic conjunctival incision. After marking two muscular branchial vessel travel in a medial rectus muscle, muscle hook is used to make two splitting in the muscle at the insertion and going posteriorly at the desired side determined. The muscle should be excited depend on the degree of medial rectus contracture and astral deviation before surgery. A blunt Westcott scissor is used to cut the muscle and leaving residual superior and inferior sleeve intact. We choose Jensen technique for transposition, the vertical rectus to the lateral. We do a phonic incision for both techniques to reduce the effect on anterior segment perfusion. Our study is prospective non-controlled study. Patient with signal palsy with abduction below the midline with active force generation test for lateral rectus at least 6 months from the beginning. They underwent medial rectal fenestration and Jensen technique and follow up at least 6 months. Here are results. 14 patients with 60 eyes, mean age of 27 years old, from 9 to 68 years old were included in this study. Intra-eye accounting for 75%, the post-operative deviation was within 10 prism diopter of optotropia. We have 4 eyes accounting for 25% had residual exotropia. This procedure was well tolerated by the patient, and it can improve external deviation before operation from 62 prism diopter to 8.56 prism diopter post-operation. A 6-month follow-up, 88.9% of eyes demonstrated greater improvement of abduction limitation. Abduction limitation pre-operation from -3.67 to -2.78. 4 eyes that did not achieve alignment were all due to undercorrection, and we have no case developed exotropia after 6-month follow-up care. We have no cases with ASI. 40, I have some cases to share with you. 41 years old man with chronic signal palsy in the right eye, and you can see after 1 year from operation, no diplopia in primary position, and greater improvement of limited abduction. 24 years old man with signal palsy in both eyes, and after 1 year's follow-up, he had residual 10 prism diopter and feel comfortable with prism based out. It is our discussion. The patient with complete signal palsy has very large deviation with whether the medial rectal contracture or not. And I think that for that condition, fenestration technique and Sense technique may be the best choice for that condition. There are clear advantages from fenestration technique over the classic medial rectal recession, reduced risk of ASI, no risk of scleral perforation, and we don't have using sutures, so no foreign body reaction or formation. However, the fenestration technique may carry the risk of bleeding. It is quite difficult in quantitation, and in the cases with severe medial rectal contracture is very difficult to do. Our study is more small follow-up care, and if you have any question, you can contact me. Thank you.
Thank you. That was a nice presentation. Any questions? So I have one more small question. So did you compare these results with any of the, because you mentioned that anti-segment ischemia is one of the main risks we need to consider when you are like operating more than 2 rectus muscles. So did you compare this with any of the belly transposition procedures like Nishizawa's procedure?
I don't have a comparative sample size to do medial rectal recession and fenestration technique.
Any questions?
You know, I'm just going to ask this question. Great talk. Thank you. So, you know, some of your patients had up to 60 prism diopters of esotropia. I just want to make sure I understand this correctly. So you did fenestration on the medial rectus muscle, and then you did the Jensen procedure on the
superior
and inferior rectus muscle next to the lateral rectus muscle. Maybe I'm the only one, but is it surprising that fenestrations would have that much impact? I mean, what do you think? I don't do the fenestrations. What are your thoughts?
Actually, we are not disinserting the muscle from its original position. Invariably, when you are saying chronic sectional palsy, they are undergoing to go medial rectus contracture. So you have to relax the muscle, you have to do the recession.
Mm-hmm.
So obviously, theoretically, recession is going to be far superior compared to fenestration. So I think author needs to explain how the fenestration is performing on par with the recession. That is probably your doubt.
Mm-hmm.
Yeah, that is the main doubt remains here.
Yes.
So just explain us how the fenestration is equivalent to medial rectus simple recession.
I always do fluorescence test before the surgery, and after doing fenestration for the medial rectus, I redo fluorescence test and make sure that fluorescence test for medial rectus is negative.
Okay. So basically, we are doing sort of relaxing myotomy. That could be one of the explanation why it is like having lesser tension. Thus, it is given leverage to the transposed muscles.
I mean, it would be very interesting to do like OCT on these patients, and I think what's going to what you're effectively doing is that you're changing the effective insertion,
Exactly.
right? Effective insertion and moving it more posteriorly.
Yes.
Great talk. Thank you.
Thank you.
It's me, right? Just a second. Okay, next speaker is Dr. Ayer Mored. Is he here? I actually did not see him. Dr. Mored? He's an amazing speaker. He's an amazing speaker. He's not here, right? Yeah, he's an amazing speaker. I was very happy to see his name on here, and you know, he's coming from Israel, so I know sometimes it can be very difficult to make it here. Hopefully he's okay. So we will go to the next speaker, Dr. Tariq Aldois. Is here or no? No? Yes? Is he here? Oh, it's
Hello
online. Okay,
everyone,
sorry.
I hope you are okay. Today I speak with surgical outcome of lateral rectus
That's okay.
recession
Can you start over? Okay, let's start over so that everyone can listen. Apologize. Yeah, I think one of the talk was
and
actually
medial
on
rectus
video.
resection in the management of exotropia among Yemeni individuals.
Let's start over again. Sorry. I know trying to do this.
Exotropia is a form of strabismus characterized by outward deviation of the eye, affecting much more than 1% of population. The condition most often present in the childhood and affect female. You are okay. Today I speak with surgical outcome of lateral rectus recession and medial rectus resection in the management of exotropia among Yemeni individuals.
Yeah, it is pre-recorded. but I
Exotropia
think
is a
we
form
got-
of strabismus
actually-
characterized by outward
Can you do it
deviation of
over?
the
Let's
eye,
start over.
affecting much more than
Yeah.
1% of population. The condition most often present in the childhood
Okay.
and affect female more than males. Control intermittent deviations can vary throughout the. Hello everyone, I hope you are
Sorry.
okay. Today I speak with surgical outcome of lateral rectus recession and medial rectus resection in the management of exotropia among Yemeni individuals. Exotropia is a form of strabismus characterized by outward deviation of the eye, affecting much more than 1% of population. The condition most often present in the childhood and affect female more than males. Control intermittent deviations can vary throughout the day. Classified as constant or intermittent exotropia, the constant or intermittent deviation eye always by one eye or my intermittent or alternating between both eyes. Sensory and consecutive exotropia are called secondary because deviations is secondary to media opacity or fundus pathology like retinoblastoma. In Yemen, unilateral lateral rectus recession combined with medial rectus resection has been suggested as surgical alternate for small and moderate angle exotropia. Recent study evaluate the surgical outcome of unilateral resected recess exotropia, the angle not more than 25% diameter. The study found that success rate defined as deviations less than 10 prism diameter was achieved at 86% of patients. Aim of study to evaluate success of recess resect of unilateral eye. Total patients of 67 patients with exotropia, all type of exodeviations with variable degree of deviations, both sex and any age group underwent surgical procedure of unilateral lateral rectus recession with resection. Patient treated at Ruwad al-Noor Eye Center, Sana'a, Yemen, from June 2022 to June 2023. Surgical intervention was done based on the prism cover test, distance at 6 meters. Also at near angle deviation, follow at next day, 1 month, 6 months from surgery, at when the final result was obtained with my orthotropic in almost of the patients. Duration, the main duration 11 months. Age of presentation, minimum 2 years, maximum 50 years old. The refraction reveal high presence of patients with normal refraction, 55%, followed by astigmatism in about 20%. Patient with myopic astigmatism, 13% remain myopic hyperopic astigmatism. Alternating squint, the majority of patients, and unilateral is 10% in the left and 9% in the right eye. Most of them are primary exotropia. The consecutive exotropia were excluded from this study. Normal limitation of extraocular motility. Anesthesia, most of them general anesthesia, less than 10% with local anesthesia, less than 5% we do surgery under topical anesthesia. Post-operative evaluation, there is 6% present with residual exotropia. Result, total of 67 patients present with pediatric department at Rwanda and New York. The mean age, 9 years. Most of them were primary, consecutive or excluded at this study. My conclusion, the success rate of unilateral lateral rectus resection combined with medial rectus resection in the treatment of exotropia among German individuals is promising. Further research is needed to evaluate the long-term outcome of surgical approach. Those are my references. Thank you.
Thank you. Any comments or questions about this? I know he's not, unfortunately, I don't think he was able to come today, but we have done research on this particular topic through
today I speak with
Pediatric eye disease
surgical
investigator
outcome
group,
of
and this
lateral
is a
rectus
topic that
resection.
there's a lot of discussion on. And any comments or questions about this? Okay.
Okay, now let's move to the next speaker. The speaker, Siddatu Muntaha Nazanin. Title is Comparison between Unilateral Lateral Rectus Resection and Medial Rectus Resection versus Bilateral Lateral Rectus Resection in Exotropia in Tertiary Eye Hospital. Please start.
Good afternoon to my audience and the panelists and chairman. I'm from Bangladesh, Dr. Sidratul Muntaha Nazneen, going to present in 40th Annual Congress of APAO 2025. President, please help me. Response?
PPT or video?
Not the video. I have the presentation in the desktop I sent here. Yeah. Yes. Now I found it. Yes. Okay. I have no conflict of interest. No, it is not happening. Let's do that. I'm giving in the speaker room, I give one presentation. Give here.
Which one, ma'am? This one?
Yeah.
This one, ma'am?
Yeah. Okay. The title of my study is Comparative Study between the Unilateral Lateral Rectus Resection and Medial Rectus Resection versus Bilateral Lateral Rectus Resection in Exotropia in Tertiary Eye Hospital. Strabismus is a Greek word which means the misalignment of the visual axis. It occurred due to the abnormalities in the binocular vision or by anomalies of neuromuscular control of ocular motility. The exotropia is a variety of the strabismus which is characterized by an outward deviation of the eyeball. It is a common condition affecting approximately 1% of all the children under 11 years of the age. The exotropia may lead to the amblyopia, impair the stereopsis, diplopia, altered cosmesis, and affect the social standing. The exotropia include the constant and intermittent exotropia. Constant exotropia is characterized with a constant angle of the deviation. And intermittent exotropia, eyes are straight sometimes and manifest with suppression on deviation at another times. The untreated, poorly controlled intermittent exotropia later progressed to the constant exotropia. The poor control suggests that the deviation is present most of the time, easy to break down, and do not recover well after the occlusion. The indication for strabismus surgery is showing the extensive deviation, poor ocular control, and loss of the binocular vision. The traditional surgical treatment has been two muscle surgery like unilateral alar resection with MR resection and bilateral lateral rectus resection. The unilateral lateral rectus resection is an alternative for small angle exotropia. The purpose of my study is to compare the effectiveness between the unilateral alar resection and medial rectus resection versus bilateral alar resection in exotropia patient in contrast of deviation. It was a prospective cohort study which was conducted in the Pediatric Department of Isfahani Hospital since January 2018 to March 2019. Total 37 patients were included in the study. The patient who having alternate exotropia and the deviation within 25 to 55 prism, they are included in the study. And the patient who having unilateral exotropia, pre-existing ocular disease, systemic disease, posterior segment pathology, they are excluded from the study. All the data are collected including the age, gender, family history, systemic and ocular illness, and the presence of the diplopia. Proper orthoptic evaluation was done including the ocular deviation, ocular motility, and PODT. Visual acuity anterior-posterior segment was evaluated in preoperative checkup. Strabismus surgery was done after getting the GA fitness. The patients are divided into two groups, group 1 and group 2. In group 1, 26 patients who are underwent monocular alar resection and MR resection. And in group 2, 11 patients bilateral alar resection. Resurgery was done for 7 patients. Now the result. The result shows the patient with the basic type intermittent exotropia with deviation between group 1 and group 2. After the surgery in the group 1, orthophoric was 57% patient, but in the group 2, 72.72% patient. Residual XT present for 10 patient and in group 2, 3 patient. In consecutive ET was for 1 patient in the group 1 and no patient found in the group 2. The number of the patient in relation with the age and the sex in the group 1, we found most of the patient found from 11 to 20 years of the age. The number of the patient in relation to the age and sex group 2, most of the patient found whose age between 0 to 10 years and 11 to 30 years. The number of the patient in relation to the deviation, most common type of the deviation was 36 to 45 prism diopter. Among them, 46% was male and 55% was female. Now the discussion. The surgical success in current study in the patient with the XT submitted to the bilateral resection was 72.2%, which is similar to the study of the Vanessa and associated other. In the monocular resection group, the success was obtained in the 57%, which is similar to the Valenzuela's study. Our statistical analysis demonstrated that the bilateral alar resection was significantly better than the unilateral lateral resection and resection surgery, although other publications considered resection better procedure for basic XT. Some authors showed the result of the both monocular and bilateral surgery together, which observed 42 patients under correction and 15 patients over correction among 131 patients. Some authors considered orthophoria plus -10 PD as the criteria for assessing the surgical success, while compensated orthophoria or esotropia were considered as surgical success in this study. So my conclusion is bilateral lateral rectus resection considered to be more effective than the monocular resection procedure. in case of basic type exotropia. This is my reference. Thank you for patience hearing.
Thank you very much. This is always a big argument. And how about the questions and discussions? Is there anybody recession is more effective? It's very difficult to.
Right. How many of you, let's take a quick straw poll. How many of you do bilateral lateral rectus recession for basic exotropia? How many of you do R&R? So about half and half. Okay. So my question to you is that why do you think, we just completed the study not too long ago through the Pediatric Eye Disease Investigator Group, and we found that the R&R was more effective, and the control of the exotropia was more lasting. So why do you think there's a difference in the findings in different groups? What are your thoughts? Because as you know, there's some papers, some group of people who suggest that R&R is superior, and some people like you, which I do, by the way, I do BLR recessions. Then regardless of what the data shows, I'm going to continue to do bilateral lateral rectus recessions, and that's what I prefer. And some people find your procedure more, find this technique more successful. So why do you think there's a difference?
Sir, I think the deviation is not stable every time. It may be one of the important cause. And also in the geographical basis, in some countries, the population varies in demographic profile. After the surgery, not getting the same result. I think this may be the cause.
Any questions or any comments? I would love to hear your comment. Remember, we don't have too many people here. Please feel very, very comfortable. I have to tell you, in a lot of the meetings in America, in the United States, I can't shut them down. They all want to talk. But when we come to Asia Pacific meetings, people seem a little bit shy. They're a lot more reserved. I think a balance will be good. I would love to hear your comments. You don't talk about, right? I would love to hear your comments. What are your thoughts?
Yeah, may I ask you one question?
Yeah. Yes,
when we are thinking about the success rate, we use not only the amount of deviation. We need to look at the stereopsis or fusion maintenance period. So how do you think of that?
Actually, we need to do the follow-up for a long period, and also we need to do the research about the cosmetic outcome also. I have another study like that. Regarding the cosmetic outcome, I define the success with the deviation, but in this study, I only show the two types of the surgery compare. So I do not show here.
Okay, thank you very much.
Okay, thank you, ma'am.
Thank you.
Thank you, everyone. So we have our next speaker, Yunun Wang. Is he here? No? So we'll move on to the 10th presentation. Dr. Saima Al-Hadrami. Yeah. Her topic is on the prevalence of different types of strabismus in strabismic Yemeni patients.
Assalamu alaikum, respected panelists and distinguished audience. Good evening. Our ancestors carved homes from mountains, leaving us a legacy of strength and resilience. This enduring spirit defines the people of Yemen. I am Dr. Saima Mohammed Al-Hadrami from Yemen, ophthalmology resident in Bangladesh Medical University. No financial disclosure. So my study topic is the prevalence of strabismus types in strabismic Yemeni patients. Strabismus is derived from Greek word that translates to eyes looking obliquely. Often strabismic eyes are referred to as squinting eyes, crossed eyes, and wall eyes. In strabismus, one or both eyes deviate inward or outward and appears to be non-alignment towards the direction of the focused object. Based on the age of onset of strabismus, it can be defined as infantile when the deviation of eyes has been noticed at or before 6 months of age. Strabismus is defined as acquired if the deviation is noticed after 6 months. These are the types of strabismus. In USA, 3 to 5% children are affected, and the national prevalence of squint is 5.4%. That means there are 7.202 million patients over 130 million. The prevalence of convergent squint varies in different parts of in the world. Esotropia is the most common. And different types of strabismus also varies according to the race. An example of this study on preschool children in Ethiopia, where esotropia was found to be the most, while in Japanese children, exotropia is the most prevalent type of squint. Methodology. My study is retrospective medical record review of cross-sectional study held between June 22 and December 24. Our patient, 1,100 samples, and all are strabismic patients, below 18 of both genders. Results. There is a slight significance of female prevalence more than male, and 509 cases below 6 years, and 696 cases between 6 and 18 years. This bar chart shows the types of refractive error, the dominance of hypermetropia followed by hypermetropic astigmatism, then myopia, then myopic astigmatism, and lastly, astigmatism, and lastly myopic astigmatism. This bar chart also showing the types of strabismus, our aim of study. There is a huge dominance of esotropia, 750 cases, and followed by exotropia, 338, and very rare few cases of hypo and hypertropia. We found 81 cases associated with Duane syndrome, retractive syndrome, and 12 cases associated with Brown syndrome. There is cases associated with paralytic squint, and happily, 25%, only 25% associated with amblyopia, and 75% without amblyopia. Our patient who need surgery, only 23 of them underwent the surgery. Discussion, we found a huge similarity between our study and the study held in Iran, Karachi, and Ethiopia, Egypt, Sohag. And that's all. These are my references. Take-home message: every child deserves the chance to see the world clearly. Timely care makes all the difference. Don't wait. Early intervention can brighten their future. Thank you. I'd like to thank Dr. Tarek Al-Duais and his team who are involved in this study. He just have video presentation virtual before me. And it's my privilege to stand before you. It was my first time today. Thank you so much.
Thank you. Thank you. Any questions?
My question to you is that, thank you very much for giving this talk. In your country,
Yes.
Yemen,
Yes, sir.
what is the incidence of myopia? Like, how does it compare to the rest of the world?
In myopia, sir, it's dominance with, not strabismus patient. It's dominance more than hypermetropia and other refractive error, sir. Yes. But in strabismic patient, hypermetropia is more.
I see.
Yes.
But is the incidence of myopia increasing? I mean, it's...
Yes, sir. Yes, sir. It's increasing, sir. Yes, sir.
I have one question. So
Yes, sir.
you said only 23% of the cases are
Yes,
ready for
sir.
surgery.
So the socioeconomic status of our patients is low, so they cannot undergo the surgery, all of them.
So it's basically more of a policy issue, government issue, because the financial...
It's a financial and somehow familial issue. They cannot trust or something like that, sir.
Okay. Any other questions? Thank you.
Thank you, sir.
Thank you. So I think, is it the last one?
Yeah.
No, okay. So this Wang, Yunnan Wang, no, this doctor's missing? Yeah. Okay. He's missing. Okay, thank you. So the last speaker is Dr. Lubavni Dewan? Is it
Yeah, it's Lubavni Dewan.
Okay,
Thank
beautiful name. Okay.
Thank you.
So pediatric third nerve palsy, clinical and demographic profile of patients presenting to a tertiary care center in South India. Thank you.
Thank you. Good afternoon, everybody. So my name is Lubavni Dewan. I'm a fellow in the final year of my training at LV Prasad Eye Institute in Hyderabad, India. I'll be talking about isolated pediatric third nerve palsy, the clinical, etiological, and the neuroimaging profile. So for background, isolated third nerve palsy in children is relatively rare, and half of these cases are considered to be congenital, with another half being secondary to causes like trauma, neoplasms, infections, inflammations, and so on. And these can come with a complex presentation, since the congenital cases are considered part of the spectrum of congenital cranial dysinnervation disorders. And the acquired cases, some of them can be life-threatening as well. So neuroimaging is considered mandatory for these cases. Also, because the standard dictums that we use for adults in terms of the pupillary involvement, these do not apply to pediatric cases because, again, they can have pupillary involvement and features of aberrant regeneration. So neuroimaging becomes mandatory for these children. The lacunae in this area are the relatively smaller case series in existing literature and the low yield of neuroimaging in existing literature that has been defined. Also, there is an absence of a defined protocol for ordering the neuroimaging in these cases. So the purpose of the current study was to understand the clinical features, the neuroimaging findings, and the etiological profile of these patients at our tertiary care referral center, and to define guidelines for the neuroimaging requisition in these cases. So this was a retrospective review of the electronic medical records carried out at Jasti V. Ramanamma Children's Eye Care Center, LVPEI, Hyderabad, and spanned a duration of 8 years, wherein we included all patients under the age of 16 years with a diagnosis of congenital or acquired third nerve palsy, and we excluded those with an alternative final diagnosis such as ocular myasthenia, CFEOM, and those with coexistent other motor cranial nerve palsy. So multiple cranial nerve palsy patients were also excluded. And these were the results. 131 case files met the inclusion and exclusion criteria, and of these, 64 were seen to be congenital and 67 were diagnosed as acquired. So on an average, the congenital cases tended to present 2 years prior to the acquired onset cases, and they had a worse logMAR visual acuity, which could probably attribute it to the dense amblyopia in these eyes. While the deviation and the motility limitation across the two groups was seen to be similar, there were some differences with regards to the severity of the ptosis, with complete ptosis being seen more often in the acquired causes. And there were some differences with regards to the aberrant regeneration prevalence at onset and at the final follow-up visit of these patients. Interestingly, progression was seen in both congenital and acquired cases. However, it was much higher in the acquired subset. With regards to pupillary involvement, this was seen in 40% of the congenital cases versus almost twice the number in the acquired cases, and most of these were in the form of a mid-dilated, poorly constricting pupil. However, a meiotic pupil was also observed in about 8% of the congenital cases, and most of these cases on neuroimaging revealed a hypoplastic or an aplastic third nerve. So these are the neuroimaging results of the congenital cases. A high-resolution Fiesta scan, that is a fast imaging employing steady-state acquisition of the oculomotor nerves, was available for a proportion of these cases, and we saw mostly a hypoplastic or an aplastic nerve in 54% of these cases, whereas some other abnormalities such as Faces syndrome or an associated corpus callosal agenesis or neurovascular conflict were reported in 12%. 12% of these cases did not yield any positive finding on the neuroimaging. The orbital imaging, however, showed variable affection of the muscles supplied by the third cranial nerve. With regards to the acquired cases, the largest category was those of post-traumatic cases, followed by inflammatory and compressive lesions. And 12% of these cases showed a isolated schwannoma or a neuroma of the oculomotor nerve. Now, this was an interesting category because this is a finding which has not been widely reported earlier. These schwannomas or neuromas were picked up as a tiny nodular or fusiform enlargement of the third nerve in its cisternal segment, as marked in this first image here, or in the cavernous segment in some of the cases. And these are seen as a T2 hyperintensity with intense post-contrast enhancement, as seen in the third panel. Most of these patients had a progressive XT and ptosis on follow-up, and one of these was in a background of systemic neurofibromatosis. The orbital imaging in most of these cases showed an extraocular muscle thinning, which is identical to those seen in congenital cases. So in summary, we saw a slightly higher proportion of acquired than congenital cases, which has also been reported previously. Pupillary involvement was seen more often in acquired than in congenital cases, and the yield of neuroimaging was seen to be slightly higher compared to existing literature. So these are the key takeaways from the study, and what we propose is a uniform imaging protocol using high-resolution MR imaging of the brain and orbit, along with cranial nerve imaging using Fiesta sequence with thin sections as a mandatory requirement in all cases of isolated pediatric third nerve palsy. Thank you for the patient listening. Thank you.
Questions or comments? Well, I just want to make a quick comment that these third nerve palsies, when you see them, especially the congenital cases or acquired cases, it's very nerve-wracking. It's a very, and of course, one of the first things that you're going to do is the imaging studies. And when you image these patients, and I think those things are very important, that you specifically mention that they track the third nerve very carefully and looking for schwannomas and neuromas, because I truly do think that those cases are missed. Even though you may write down third nerve palsy and please evaluate third nerve, it's one of those things that I think it can easily be overlooked. So if it's possible, I think it's important for you to try to get used to looking at these images yourself. I think that's very, very helpful. But also having a close working relationship with your neurologist and radiologist, I think is truly the key. But great talk. And then I actually had a patient with the migraine-induced third nerve palsy not too long ago. And these things are really nerve-wracking because they come and go, as they can actually resolve on its own, and then they can come back years later. So these third nerve palsies, I think it can be really difficult. And of course, the surgical management is another whole topic in itself, which can, I think some of those things will be addressed at this APIO meeting. So any other comments or questions you wanted to bring up for any of the speakers? Well, thank you very much. I think we're going to finish a little bit early, and I hope to see all of you at the opening ceremony tonight. Thank you, everybody. Oh, group photos, yes.
All the speakers, please.
All the speakers. All the speakers, can you guys come to the front? We'll have a group photos.